The second sector of the antibody mediated rejection is the treatment. How to treat this patient. The focus of this presentation, I'll present the different modalities and armamentariums of treatment of antibody mediated rejection, and then I present a case from Mansoura Urology and Nephrology Center, and I end with my conclusions and recommendations. So the therapeutics for antibody mediated rejections include suppression of the T-cell dependent antibody response by giving the patient the maintenance immune suppression steroids, cyclosporin, tacrolimus, and sirolimus. The removal of donor reactive antibodies by plasma exchange or pheresis. The blockage of the residual alloantibody by IVIG. Depletion of the naive and the memory B cell by rituximab. Inactivation of plasma cell by bortezomib, which is antagonistic for plasma cell, and then blockage of complement component that blocks the effector arm of immunity by blocking the membrane attack pathway by eculizumab. If you look to this slide summarizes all the B-cell targeted therapy. So it may be B-cell depletion and antibody depletions or inhibition of antibody functions. And I think there is no time to explain all these issues. One of the most important issues in the treatment of antibody mediated rejection is to follow up the concentration of donor-specific antibody after treatment. So donor-specific antibody is very vital for diagnosis, and its function in treatment is to monitor the responsiveness to anti-humoral therapy. So if you have a patient who developed antibody mediated rejection and is treated with these treatments, and you follow donor-specific antibody and you find that donor-specific antibody is decreased tremendously, the outcome is good. But if there is no reduction of donor-specific antibody, graft survival is affected and graft failure is a rule. There is an FDA workshop that discussed different modalities of treatment of antibody mediated rejections. It discussed all modalities I mentioned, but if you look at the number of patients included in each study, you'll find here 7 patients, 5 patients, 10 patients, 3 patients, 16 patients, 5 patients, and again the number of patients included in each study is not so big. So this studies summarizes the different modalities used in treatment of antibody mediated rejection. One of the important drugs in this armamentarium is rituximab, which is antibody against CD20. So it affects B cell, and this is the vial. So this is one of the cases. Here the diagnosis is confirmed as antibody mediated rejection. The patient is treated with the classic treatment, IVIG and the plasma exchange. And after this time period, 2 weeks, no response, so rebiopsy was done. Again, the classic treatment is continued. Another third, the biopsy was done. The same pathology is present, so rituximab was added at this time point that reversed the antibody mediated rejection. In Mansoura Urology and Nephrology Center, we have a protocol for the management of antibody mediated rejection that included IV methylprednisolone, plasmapheresis, and rituximab given as intravenous infusion, 375 milligram per square meter. And this is among the thesis of my colleague Dr. Hisham Ammar. And the initial results that this protocol is efficient without major side effects. Another important drug, which is bortezomib, and the bortezomib can be used as induction therapy because it depletes plasma cell. So if you induce the patient with bortezomib and you follow the patient with immune suppressive maintenance, either low dose prednisolone, moderate dose or high dose prednisolone, or prednisolone plus other immune suppressive drug. If you look here, if you follow the patients with low dose, after 3 months, 50 patients will develop donor-specific antibody, and by a year, 80% develop antibody. Even in high dose group or patient with triple immune suppressive drugs, within a year, more than 50% will develop donor-specific antibody. What I want to say, even if you give bortezomib to the patient in induction, you should follow these patients with donor-specific antibody to risk stratify the patients and to treat the patient efficiently before the development of the full-blown pathology of antibody-mediated rejection. Another important point in the resistant cases, bortezomib can be used. If you treat the patient with rituximab and no response, you can treat the patient with bortezomib, and bortezomib is given in 4 dosages, so it's given day 1, 4, 8, and 11, and beside the IVIG, as you see here in this slide, and the dosage of bortezomib is 1.3 milligram per square meter in each dose, and then the major adverse events include fever, chills, rigors, nausea, vomiting, diarrhea, dehydrations, edema, bone marrow suppression, infection, liver dysfunction, and symptoms of peritubular peripheral neuropathy. So if you look carefully, if you treat the patients while the creatinine is relatively good, so creatinine below 3 milligram per deciliter, you will find a good outcome. If you are treating a patient with higher creatinine, the outcome is affected. So serum creatinine before treating the patients with bortezomib is important to prognostically to know the effect. Another point, if you are working in delayed fashion, if you are treating late rejection, one of the important issues in the treatment of the patients with antibody-mediated rejection is either you are treating the patient early or late. If you look at this slide, you'll find if you treat the patient earlier, the potency of bortezomib in reducing the level of donor-specific antibody is potent in comparison to a late one. And here is not only donor-specific antibody, but the preservation of estimated GFR. So the earlier the treatment, the better the outcome, and the late the treatment, the worse the outcome. Another point is there is any comparative study that assessed the potency of either rituximab or bortezomib. This study showed that there is some beneficial effects of bortezomib in comparison to rituximab, but still we are waiting the results of more and more studies. The eculizumab, which is the inhibitor of C5 complement, and as I mentioned before, it affects the effector arm of immunity, so it doesn't deplete the antibodies. So we should follow the patient serially by the presence of antibody giving serial dosage. As you see here, the arrows reflect the dosage 1,200 milligram, or as you see 600 milligram, and every time we assess the immunity, if there is antibody or the antibody decrease below a certain point. If antibody is not decreased, we should give supplementation of the dosage and repeating the evaluation of the donor-specific antibody. Because we are not depleting antibody, just we stopping the effector arm of immunity, and this is reflected by high cost. And the anti-C5 eculizumab is very effective in treating the resistant case of antibody-mediated rejection. As you know, if you inhibit C5, you will inhibit the membrane attack pathway, so you will inhibit the expression of C9 in the biopsy. So if you look carefully here in this slide, C9 is deposited before the treatment, but when you give eculizumab, C9 is inhibited in the pathology. One of the treatment or modalities for antibody-mediated rejection is splenectomy. Why splenectomy is one of the modalities of treating antibody-mediated rejection? Because spleen is a lymphoid organ that enriches the immunity of the patients, and this is one of the studies in cardiac transplantation showed that spleen is a major source of anti-donor antibody secreted in murine heart allograft recipients. And it was experienced in this study that included 4 patients, and after doing splenectomy, as you see, creatinine improved in all these 4 patients. Another study here, this is be careful, because sometimes antibody-mediated rejection is due to anti-endothelial antibody that may lead to hyperacute rejection, as you see in this case. This case was exposed to 2 episodes of hyperacute rejection with graft nephrectomy, and the third one is treated with bortezomib, but unfortunately the third graft was lost because of antibody-mediated rejection because of anti-endothelial antibodies. And this is regarding the treatment of acute antibody-mediated rejection. What about the treatment of chronic antibody-mediated rejection? This is pediatric experience in 6 cases. The patients were treated with 4 weekly dosages of IVIG, 1 gram per kg per dose, followed by single dose of rituximab, 375 milligram per square meter surface area, 1 week after the last IVIG infusion. And if you look to the slide, here the GFR is decreased before the treatment and after treatment, find increasing in the GFR, improvement of kidney function. In adults, in 4 cases, again, rituximab and IVIG are good for treating the chronic antibody-mediated rejection. Here we should give the patient the maintenance immune suppression, as you see here, tacrolimus given by these dosages and maintained on 0.1 milligram per kg per day and monitored by the tacrolimus level. MMF starting with 2 grams and then 1.5 gram after that period, and giving the methylprednisolone in this way and maintaining the patient on prednisolone later. And here in these patients, these are patients with ABO incompatibility, so the patient were allocated to 3 arms of treatment beside all these immune suppressive, either splenectomy or rituximab or control without splenectomy or rituximab. So doing splenectomy or treating the patient with rituximab are superior. These 2 groups are superior to the control arm in reversing the hemorrhage process. If you have mixed acute cellular rejection and acute antibody-mediated rejection, and we know that bortezomib is specific for the plasma cell, so there is a role for bortezomib in treating this mixed reaction. In this 6 case, yes, bortezomib provides effective therapy for antibody and the cell-mediated acute rejection, because although it inhibits the plasma cell, so it inhibits the hemorrhage arm, it also affects the activated T cell and as you see, the mitochondria, nuclear factor kappa B. So bortezomib, yes, it is a potent anti-humoral, but also affects cellular arm of immunity. When we review the KDIGO guidelines in treatment of antibody-mediated rejection, the KDIGO guidelines suggest treating antibody-mediated acute rejection with 1 or more of the following alternatives, with or without corticosteroids, plasma exchange, intravenous IVIG, anti-CD20 rituximab, and lymphocyte depleting antibodies. But if you look to the evidence, it is just suggestion and based on weak evidence or not strong evidence. How to change the face of antibody-mediated rejection? I am a great believer in the statement of the Professor Dennis Gilling, who stated that one of the major inventions in the last century is the development of clinical trial that changed the face of medicine. So we are waiting superb clinical trials. We are waiting the development of guidelines in management of chronic antibody-mediated rejection too. This is a case from Mansoura Urology and Referral Center. This is a 47-year-old male patient who suffered from end-stage kidney disease and was maintained on dialysis until he received the first kidney transplant in 1992 and maintained on triple immune suppression, prednisolone, cyclosporine, and azathioprine. He developed 2 acute rejections in the 2nd month and after 2 years that were treated efficiently with pulse steroids, and eventually developed the chronic rejection and graft failure and resumed hemodialysis in 2003. Again, he was retransplanted in 2004. Unfortunately, he developed severe form of rejection that ends with cortical necrosis and with failure of treating this patient with anti-synuclein globulin. So the patient was maintained on dialysis for 3.5 years and prepared for the 3rd transplantation from unrelated donor, 35-year-old male, same blood group, 3/6 mismatch of HLA. At time of transplantation, so the current BRA was 0 against class 1, 29 and donor specific for class 2. But immediately after the failure of the 2nd graft, there was peak antibodies of 90% for class 1 and 2. So this is just to show the importance of current and the peak. We treat these patients carefully, so we prepared him with plasmapheresis, although the cross-match was repeatedly negative, and MMF was initiated 2 weeks before transplantation, and he was transplanted in November 2007, ischemia time 60 minutes, immediate diuresis, and maintained immune suppression, basiliximab, prednisolone, tacrolimus, and the MMF. After transplantation, there was immediate diuresis, was urine output 7 liter, creatinine decreased from 10 to 4.1 with perfect graft perfusion. second day immediately there was significant oliguria, 0.5 liter, and creatinine increased from 4.1 to 4.6 with impairment of the graft perfusion. So the decision was immediate treatment of the patients, and doing biopsy. The biopsy showed the full blown picture of acute antibody mediated rejection, and we repeated the evaluation of donor-specific antibody, and we found the presence of donor-specific antibody against both class 1 and 2, and the patient was treated with plasmapheresis, rituximab, and hemodialysis was initiated to support the patients. With marked improvement in everything, the urine increase, creatinine decrease, and currently the patient has serum creatinine about 9 milligram per deciliter. To sum up, to treat antibody-mediated rejection and to manage antibody-mediated rejection, the multidisciplinary team approach is mandatory. So there is no one man show in the transplantation. So immunological lab, full equipped lab, pathology lab, transplant surgeon, nephrologist, radiologist, you should be working together plus other labs, microbiology, etc. for the success of transplantation in general. But if you ask me what the most important lab is, the immunological lab. So it was monitoring, adequate monitoring of the donor-specific antibody. So by good immunology lab, we can grade the patient, we can grade the risk of immunological risk into very high risk. If the T-cell cross-match is positive, we can expect a hyperacute rejection. We can't transplant the patient with positive T-cell cross-match. We should desensitize them first. And then if the cross-match is negative, but Luminex is positive, you can find that you are here and the human rejection is present. If no antibody by the Luminex, the patient is in the low-risk zone. So the dogma is prevention is better than cure. So an ounce of prevention is worth a pound of cure. So how to prevent is just to be meticulously evaluating the patient, assessing the risk, respecting the patient history, and serially evaluating the patient non-invasively by following up the presence or the titer of donor-specific antibody. So one of the new drugs armamentarium is the belimumab, which is BLYS, human monoclonal antibody, that inhibit the proliferation of B cell. It was approved by FDA last year for the treatment of lupus nephritis, although it's not so efficient in the management of lupus flare, and is now under testing for the antibody-mediated rejection at one of the most prestigious hospitals in the UK, which is Edinburgh Hospital in Cambridge, and we are waiting the result of this study. One of the important items is to assess the adherence of the patient to treatment. If you look here, this study showed that the majority of the failure of the graft are due to the antibody process, and 50% of these antibody-related issues are related to non-adherence. So we should educate, and as Kidigo stated, consider providing all kidney transplant recipients and the family members with education in prevention and treatment measures to minimize non-adherence to immune suppressive medication, even if the graft is perfect, and considering providing kidney transplant recipients at increased risk for non-adherence with increased level of screening for non-adherence. So it is very important and crucial that the patient should follow the medicine and follow the direction of the doctor. Another point, is it mandatory to do desensitization? Yes, desensitization is very important if you have a patient with donor-specific antibody, because if you leave the patient on dialysis, the survival is affected drastically. But instead of doing desensitization, we can activate the donor, the two-pair exchange. So if you have two couples and the recipient is not fit for the donor because of immunological risk, you can change the donor from the first couple to the second couple and vice versa. And by this way, you solve the problems of sensitization and you offer the best situation for the both couple or the three-pair, or even if you have altruistic donor for the center, it can open a chain of the high-risk couples. Just to sum up, how to face the challenge in medicine generally and antibody-mediated rejection is we should consider that success belongs only to those who are willing to work harder than anyone else. So we should be active. As Wu said, to succeed you must first improve. To improve you must first practice. To practice you must first learn. And to learn you must first fail. But my impression is when we treat a patient with antibody mediation and we failed, we should improve our service and learn, and then practicing and improving the service. And then if we improve our service, we can succeed. And thank you for attention.